Welcome to another conversation with Joe Reagan. Today, Joe, I am sick. I am absolutely sick about our healthcare system. And you know what? Watching these stupid ads on TV for medication and getting down to the side effects where you get diarrhea, blurred vision, constipation, extra hangnails, and by the way, death.
It's al- it's always
So,
it's always it's always a symptom. It can always be a symptom, I guess.
yeah, I mean, it's spooky and it's scary. I
It
mean,
is.
Joe, what can we
Yeah.
do about it?
There's a number of different things that we can get into, and I think this digs in a lot to the cost of healthcare. And one of the things that we don't get a chance to talk about, we spend a lot of time talking about who pays. So you have obviously a lot many members of the Democratic Party, like Bernie Sanders, really believe strongly in the Medicare for all.
Hmm.
And on the other end of that spectrum, you have Republicans that, even in this Congress, are still trying to pull back the Affordable Care Act. So, but we don't spend enough time talking about what actually drives the cost of healthcare. It makes it so high. And this is something that, for me, I've always found very fascinating because when you work in a nonprofit healthcare setting, you you start to understand a little bit more about the economics of how, and I don't mean economics in a profiteering perspective, but even in a nonprofit realm, the challenge is, how do you keep those lights on? And it really comes down to, with the way that our medical billing system is structured, you get reimbursement based on the treatment, which generally speaking is, if I can do a test and add a prescription to it, then I'm going to get money for that, for those services, a fee for service model. And it doesn't matter if you're on private insurance or Medicare, Medicaid, or even if you show up to the emergency room and have no insurance whatsoever. At the end of the day, the hospital is required by law to pay for that, and that money comes from somewhere. And generally speaking, because, and if you understand Medicare, Medicaid, and the way those reimbursements work, it's about 75 to 85% of cost is what Medicare, Medicaid will reimburse a provider for. So what that then does, if you're designing the billing structure and designing the cost, and this is why we need more. What we really need to do is promote transparency in cost, because what you then do is essentially you inflate your cost to incorporate the non-reimbursable expenses that are incurred by the organization. So your emergency department, if someone shows up and you know that perhaps 10% of your emergency room population will show up uninsured, then you know the cost of that. And then you will spread that cost out across your other patient costs. So that when you or I show up, and Gary, you as a military retiree, you are on the TRICARE program. So if you show up to a hospital, your insurance is actually getting billed for more than the cost that it was to treat you personally. And that's because they're essentially charging your insurance to cover the cost of the uninsured person that showed up, or at least a small portion of that. And that's just, how do you keep the lights open? And part of what that does is it makes healthcare into the Amazon, what I call the Amazon model, which is not a good thing, where it's all about volume. Again, to go back to, how does Amazon stay open and why are they so successful? And it's because they're not focused on profit margin, but they're focused on volume. And so because Amazon, and the same thing with Walmart and Target for that matter, because they can do a higher volume of sales, they can do it at a lower profit margin, and that then creates greater profit from a financial standpoint. So if you're a healthcare provider, it's really the same thing, where it's now created healthcare into a volume game of, well, I have to be able to have so many patients that come in, because otherwise I can't cover the non-reimbursable expenses that I'm required by law to do. And that's not a bad thing. At the end of the day, we you don't want to be turning someone away from healthcare because of because of financial reasons, right? We should be treated first and then figure out the payments later. So what this does though is, especially in rural communities, they simply can't get the volume they need in order to provide that level of care. So that's why we're seeing so many healthcare deserts emerge in rural areas, because financially the model just doesn't work there, because you don't have the patient density to achieve the volume necessary for those doors to remain open. So this hurts private providers, it hurts private practice doctors, and ultimately it really is encouraged an overconsolidation in the healthcare marketplace. And so this is where you see the major healthcare companies, major hospital corporations that have emerged, because they can play that Amazon game where they can bring a high volume of patients in, and that helps them to pay for those things. And pharmaceuticals is a big component of that, because at the end of the day, for the longest time, and again, if you understand anything about the different sectors of a hospital, the emergency department, the ED, is the most expensive, least profitable part of the hospital. In fact, that's where most of you're pretty much, your emergency department pretty much operates at a loss.
Well, your emergency departments, at least in this town, and I'm sure other cities, is outsourced to
Yes.
other organizations. And is the treatment as good? From my experience, no.
No.
Okay.
Well, and then you also have to go back to, now we've created a system where there's different variations of what an emergency department is going to look like. And so you have urgent care, which is where we push a lot of people, and there's a slightly better profit margin. And if I don't remember this myself, remind me to tell the story about the urgent care. And then you have, essentially what we're trying to get to, and this is a huge issue down in the south part of town, specifically in the Fountain area, which is access to a level one trauma facility. And
Mm-hmm.
this is really where you have access to an operating room, and that's, so any sort of emergency can be handled in a level one trauma facility. And that is a big challenge, because we don't necessarily have that. So when you're outsourcing some of these emergency department functions, it's typically not going to be level one. So you're getting someone into the emergency department for triage, which is kind of like urgent care plus. And if you need to get them to level one, then that's why, if you're pretty much anywhere along the 115 corridor, you're always seeing helicopters go overhead, because that's the medevac flights that are taking folks from some of those outsourced departments and bringing them into the level one treatment facilities that we have at Memorial, and then the one up north as well. So and again, that's a huge driver of cost too, which is, now if I have to add a medevac flight into this, suddenly what could have been just a ambulance ride is now turning into a $1 million helicopter flight as well. So this is all driving costs. But your question was on pharmaceuticals, and so emergency room department is operating at a loss, and we've tried to outsource that because we want to minimize that cost and that loss. For the long time, it was the radiology department that was really the profit
Mm-hmm.
driver of the hospital, where you could have your imaging machines would go in, you could run diagnostics, and the reimbursement for the diagnostic test on this is X-ray, MRI, CAT scans, these
Mm-hmm.
sorts of things. There's a huge profit margin on that. So getting someone to go through and to do an MRI scan or an X-ray or something like that, that was driving a lot of profit for the hospital. And again, I want to be clear when we're talking about this. When I say profit, I mean you're able to charge more than the actual cost of what the operating expense is of that. And most of these hospitals do, in fact, operate in a nonprofit environment, but you have different cost centers that will offset losses in other areas. This isn't necessarily one of those evil hospital executives trying to profiteer off of this. This is really trying to manage the cost of what it costs to deliver healthcare. And again, it's a conversation that we're not really having, of how do we drive down those costs. So because of a couple of different factors over the years, and this is where you saw like imaging centers started to become really popular, because imaging centers realized, well, oh, I can actually operate at a huge profit, and not have necessarily the line that you see in the hospital, and open it up for different things. So that's why imaging centers evolved. That actually drove the cost down on imaging the radiology departments. It made it somewhat less profitable. And so what you were left with is now one of the most profitable sectors of the hospital is the pharmacy. And that's where you see a lot of excuse me, that's where you see a lot of cost being offset is, well, if I can prescribe something, then I can also make the profit there. And this doesn't even take into account the pharmacy benefit managers and all the other factors that go into how we distribute pharmaceuticals in this country. Excuse me for 1 second.
Still drinking on the job.
And that is my delicious sparkling water that again, one of those things, if you see me out and about, I almost certainly have one of those by my side. And that is not an advertisement. The other challenge with pharmaceuticals, and this is something that I thought was really interesting, the global pharmaceutical market. One of the areas, the U.S. spends more on healthcare R&D than any other
Right.
country in the world,
Where do they spend the money?
mostly in the pharmaceuticals.
No. Where do they spend the money
Uh-oh,
for
you froze.
pharmaceuticals?
Within the research and development or within the advertising you're
Research and
talking
development.
about?
Spent in universities.
Yes.
Okay.
Well, not necessarily. If you look at the big corporations like Merck, they have internal labs that do a lot of this stuff.
Mm-hmm.
Abbott has a lot of internal labs that they use to develop not just pharmaceuticals, but also testing.
Mm-hmm.
So, for example, the COVID test was originally developed at a lab facility. It was in Maine, actually. And so these facilities, and this is where another area that you hear talked about somewhat, it kind of sneaks into the conversation sometimes. Excuse me again.
Well, I was going to mention that university hospitals like Harvard, which is being picked on right now,
Hmm.
does a lot of research into healthcare and period. I mean, and of course, they're being threatened to cut their funds off. And of course, I think our good congressman here, Jeff Crank, is just cheering that on.
Yep.
But
And and quite frankly, that reflects his fundamental lack of understanding of how the whole system works.
mhm,
And I'm not saying that to be the defender of, the system, but I am saying that to say, when we look at how things operate, and right, if you really want to implement change, you have to understand how and why things are currently done. And the current administration, Jeff Crank, really they don't have a fundamental understanding of how things operate today.
that's what
Is
they have editing for.
Oh, good. Then I won't explain why I'm coughing. We'll have to have a gag reel. The You talk about hospitals and R&D facilities.
Hmm.
So when you look at the pharmaceutical market specifically, I think the what we understand about that is it's about 1 out of every 20 compounds discovered will actually lead to a profitable drug. So when you look at Tylenol, there were 19 other variations of Tylenol that didn't do anything. But someone experimented with it to try and figure out what it was, and ultimately said they found Tylenol and said, "Hey, all right, this is a good painkiller, and now we can market this."
Yeah.
So when you look at intellectual property protection in the healthcare space, specifically the pharmaceutical space, this is an area where, and uh, I will use a gender affirming drug known as Viagra that was originally, I saw your face in that one. This is a drug that was originally discovered, or compound that was originally discovered for low blood pressure. And I think most compounds have about a 10-year uh, protection on it. So essentially, once a compound is discovered, that pharmaceutical company then has sole proprietorship of that compound for 10 years. And that is the only time frame that they will have where they can actually make a profit off that drug, because they will be the sole organization that can produce and sell that compound. And that's where we see your kind of your knockoff pharmaceuticals and that, or your off-brand pharmaceuticals. These are compounds that have exceeded that limit, and now someone else has been able to go in, realize what the compound is, produce it for less, and flood the market with it.
You're talking about generics.
You're talking about the generics. Thank you. The It's been a long day.
It's been a
The
long day.
the so what the trick has become in the pharmaceutical industry is drugs like Viagra. The compound was discovered for one purpose, and then someone realized, oh, we can also use it for this other thing,
Hmm.
and so then it's remarketed. That starts a new timeline. That 10-year mark continues to go, so that compound stays was the sole property of that pharmaceutical company. And again, it's an area that a lot of folks have looked at and said, we really need to be able to change that because we're kind of messing with the free market here in that once you produce it, if somebody else is able to reproduce it for a lesser cost, well, we should be in some cases, we should be encouraging that. And the problem is that with R&D costs, there is a balance there, right? At the end of the day, again, go back to my Tylenol analogy of if it took 20 different compounds to get one Tylenol, what's paying for those other 19 to be discovered? Hospitals, research hospitals, like the one that exists at Harvard and, many across the country, they're doing a lot of that work and they can do it at a lesser cost because they're able
Right.
to use essentially students
Hmm.
as part of that process to do the early phase research and development. Now, the healthcare industry doesn't look at it the same way, but I'm gonna kind of lean on my background in the tech space here for a second because when the government looks at technology, they use what's called the technology readiness level to assess at what phase a certain technology is at. So when you think of um, a cell phone, a cell phone is TRL 10. It is fully developed. It is out in the market. There's multiple versions of it. Um, Quantum technology, quantum encryption is at like a TRL 3, meaning it's really still only happening in the research environment. There's not really a commercialized product. You have some programs that are advertising quantum technology, but for the most part, you're only going to find that technology in the with pharmaceuticals. It's kind of the same thing where these early phase drugs, these early phase compounds, you know, the failure rate on it is so high that it's really hard for an investor to look at that and say, we're going to get behind it. And if you look at pretty much any technology on the market today, that started with the government. And actually, Pete Buttigieg did a great job the other night talking about this. He used the internet as an example and said, if you were an investor in the 1960s, would you have spent a dime on a technology for people to send information remotely by computer? And they said, no, because in the 60s, this technology did not exist. This is not how we do things. And the technology was so immature that, of course, nobody even knew if it could be done. But the government got behind it and said, well, we think there's potential here. So the government made that investment. And this is why, this is why Silicon Valley exists. Silicon Valley was originally a DoD facility that was developing technology for radar. And that's where they discovered how the silicon chips can do all the things that they do. So that's to say is that when you see the administration cut back on these research funds to organizations like Harvard, at the end of the day, you are cutting that pipeline for new medications, new drugs, new technologies and one of the areas that we need to be making a greater investment in right now are those technologies that can reduce the R&D cost. And so when you look at computer simulations, we can start to leverage and make investments in those sorts of artificial intelligence softwares that can model what these compounds will do without actually having to create the compounds themselves. And
Hmm.
that's an area where, so go back to my discussion of how this whole thing works. And if we can reduce the cost of R&D, then you can start to promote your generics sooner into the process, because now the incentive, or really the demand, to hold on to a compound for an extended period of time no longer exists, because now that cost isn't there. You can shift those R&D dollars elsewhere to be doing more productive work.
Well, kind of going back a little bit here, you're right. If there's new technology, you're not going to get anybody,
Mm,
private investors, to invest in it. And the government has been involved in so many things that have
yep.
been used in the consumer world, microwave ovens,
Hmm.
for starters. And I'm sure this is before your time. You were probably not in a twinkle in your father's eye, but Corning Glass Works, that came out of the space program because that
Hmm.
was the heat shield on the capsules that they were using back in the 60s.
Yep.
And that's where your glass top ranges came from. And transistors and all that crap, excuse me, that
Hmm.
was invented and that a lot of consumer products come out of. And one thing that's popped up today in the news is that with the tariffs happening, now it's going to affect the compounds used in drug manufacturing because it's either not going to be coming in the country or it's going to be held offshore until somebody makes their mind up what they're going to do.
Yep.
But I believe you're going to start seeing shortages in the pharmaceutical end. And so that takes it back to the hospital saying, okay, one of your profit centers just took a hit because of being unable to manufacture the drugs using the compounds that are sitting out there in a boat somewhere.
Hmm.
And so I just think that what's happening. It's basically a double hit in the healthcare industry. I mean,
Yeah.
you're having the federal government cut off funding for R&D. You have the federal government imposing tariffs on compounds coming into the country from China. That's where most of the stuff is coming from
Hmm.
at 145% tariff. So, I mean, stand by to stand by.
Yep. And again, and we've had this conversation in the past where you really can't find a single economist out there that says the model that we're looking at is going to do anything that the administration says it's going
Oh,
to.
yeah. One other thing, this is what I want a theory on your part. You're
Okay.
talking about rural hospitals.
Hmm.
I read MedPage Today
Okay.
quite frequently, and they have a lot of good news in the healthcare industry. And they usually are ahead of the game when it comes to being able to forecast actions.
Hmm.
And they were talking about rural hospitals closing and even some inner city hospitals closing
Yep.
because of the lack of funding. And of course, with the $880 billion cut in Medicaid, it's really going to hurt the inner city hospitals
Hmm.
and the rural hospitals. And I came up with a concept that why worry about these corporations that are going to be closing these hospitals when the city or the counties can take those hospitals over and make them municipal hospitals and still provide health care. That way, your local EMT at the volunteer fire department is not going to be performing CPR on you anytime
Hmm.
soon. And what do you think of that idea of this? Because right here in Colorado Springs, the city still owns the hospital,
Yeah.
even though it's managed by another organization, which I will not say. But I believe in municipal or city owned or county owned facilities because they're the only ones who can keep the doors open.
Well, I would say this, and where the, I think you're right. I think having greater, I think having a greater municipal responsibility on the healthcare infrastructure is part of that solution. The challenge is that, go back to my comment, who's paying the bill doesn't necessarily change the reality of what we're talking about. And
Right?
so if the city of Colorado Springs were to take back ownership, full ownership and operatorship of these hospitals, they would still be struggling with the same cost dynamics that the private hospitals are. And remember, again, these are private hospital corporations, but they do function in a primarily in a nonprofit sense. So it's not like they're operating on a tremendous profit margin. The volume margin brings in big dollars,
Mhm.
and that's and like I said, and that's the challenge. So the difference is, if a municipality brings this on and they're still trying, and again, this is a, you got to keep the lights on, and that means you got to have, and on a, if we can use the mayor's attempt to get the fire department to take on ambulance services, that is a great example of, and there was a lot of thought that went behind that, where bringing the hospital or bringing the ambulance service under the fire department was actually going to save the city a tremendous amount of money. And the city council said no to it for a number of different reasons, principally because there was a risk associated with it. So that was the challenge. The mayor had done the math on it and said, hey, we can actually save a little bit of money, and we can guarantee services. We have more control over this. But what they didn't incorporate, and the problem with any of these economic forecasts is there's an element of, well, what happens if some of these assumptions are wrong and some of these cost drivers shift? And then that puts the burden back on us as taxpayers, where, hey, we really messed up. And because now the pharmacy isn't as profitable as we thought it was, and now our municipal hospital is operating at a deficit, now we have to go back to taxpayers and either do a bond. We got to raise taxes to make sure we keep the lights on. And I'm not saying that's not a reason against it, for me at least. But like I said, it's part of that fiscal reality of what that might look like. So if we were to do it, you'd have to make sure that forecasting, those assessments, those assumptions were really thought out. But at the same time, in communities like Fountain, you are seeing that happen right now, where they're not closing a hospital. They've never had one. And nobody has made any emphasis on putting that sort of trauma facility out there. And I don't know about you, but I've done the math, because I've driven from Fountain to Memorial
Mhm.
Hospital, which is the closest one. And even on a good day, it takes me probably 45 minutes to make that
Understand,
drive.
understand.
And so,
And that's a subject for another podcast, but because it's history is what we have to talk
mhm,
about here. But getting back into our healthcare system, yeah, it's broken.
mhm,
It needs help. It needs to be resuscitated. And it's just a matter of the political will, because when you have a congressman voting to take away coverage of health care via Medicaid and Medicare and SNAP and WIC and everything like that, it's an uphill battle at that point in time.
it is. And I'll say this, to our Democratic friends that listen, and that probably listen in greater numbers, right? That statement is 100% accurate. But to our Republican friends, we also have to look at that and say, it sounds good. It might sound good to some folks when you say, well, we're going to cut $80 billion in expense so that we, don't have to, so that we can help balance the budget. That might sound good to folks. But what's missing from that is, like I said, if you cut 80 billion or $800 billion
Yeah,
from Medicaid, well, guess what? You're going to have to spend $100 billion more somewhere else, because
right,
that healthcare need is not going to go away. And
right.
if it's not covered and reimbursed through Medicaid, it will have to be paid for somewhere else. And
Well,
that is what's missing from the conversation. And like I said, to our conservative, to our Republican friends, we have to be able to have that side of the conversation as well as saying, yes, I understand that when you say, well, we're not going to spend this, that's not the end of the story. You're
no.
not going to spend that on Medicaid. You're going to spend more somewhere else. And
Right.
it's going to be either it's going to be put back on private insurers, it's going to be an increase in cost. I mean, it could be medical debt that
Yeah.
these hospitals have to take on, causing further consolidation and causing this even further stress in the system.
Yeah. Well,
And the same, go
right
ahead.
here in congressional 5th district, we have 147,000 people that are on Medicaid
Mm-hmm.
out of a population of 500,000.
Yep.
Run the numbers, folks.
Yeah.
I
Well, and
mean,
let me say this, and again, I hope my Republican friends listen to this one because credit to Jeff Hurt down in CD3, who is one
mhm,
of the very few Republicans in Congress that has been willing to stand up against those cuts. And I
yes.
think that's because the realization is he looked at his district
Hmm.
and said, hey, this isn't right for my district. I
Yeah.
can't vote for this.
Yeah.
Yeah, maybe my party's behind it, but I can't vote for this because this is going to hurt people in my district.
Yeah.
And this has been my case since the moment I started running of this isn't about Democrat or Republican politics. It's about doing what's right for the community. And right now, when it comes to the healthcare argument and so many others,
Yeah.
Jeff Crank is not voting to benefit the people of this district.
Oh,
And
no.
I think that and we have the numbers to show whether you're a Democrat or Republican, the numbers show that. And I know Democrats get upset with me sometimes because they say, "Hey, you talk a lot like Republican," and it's because I look at the values of the Democratic Party. I look at the
Mhm.
policies that the party implements, and I'd say these are just more effective policies. And even what the Republicans are saying they want to do, the Democrats have the actual answer for it. So let's take that and make sure that we're communicating that to our Republican friends and say, yeah, we agree that we're spending too much in healthcare. We've got the solution. Let's do it. And you also mentioned like the SNAP benefits and stuff like that because it goes beyond just the healthcare argument.
Right.
Where if you're not funding SNAP benefits, other social welfare programs that help with folks with access to food, and we're seeing this. If you talk to some of my friends at Care and Share, they will tell you the same thing. Where their funding is getting cut, it is making it more difficult to put food on the table. That leads to short and long-term health benefits or negatives. And so when you cut those SNAP benefits, again, on paper, hey, we didn't spend this amount of money on SNAP. Well,
Mhm.
guess what? You're gonna spend that money somewhere else.
Mhm.
And it can be a little bit harder to account for, but I can guarantee you that any cut to Medicaid, any cut to SNAP, that is going to result in a much greater cost somewhere else in the budget.
Okay, Joe, we just burned through another 33 minutes and 40 seconds. So thank you, Joe. You got any final thoughts before we wrap this puppy up? Because I think you have to mention two things in the end here.
That's right. That's that. I appreciate the prompt of, again, we try and post a lot of stuff onto the Reagan for Colorado webpage. You can also learn more about it. We're always revamping that. Again, we're still early in this cycle, so right now it's just me.
Yeah.
And but also, Gary, you've done a great job of taking our conversations and putting it out there on Amazon, on Spotify. We're on YouTube now, and on Facebook. So the strategy. I've told people this. This is not a secret. The Reagan strategy for winning CD5 in 2026 is not a secret. It's we need to get out there. We need to be seen. We need people to hear these in-depth conversations because when you look at the sound bites that Jeff puts out in his Crank It Up newsletter, it is not reflective of what the reality of people in CD5 are experiencing.
Yeah.
And I ran because I wanted to represent El Paso County, our friends and neighbors, and whether it was Lamborn or now Jeff, neither one has voted to support the people of this district, and
Including veterans.
especially veterans.
Okay.
And so we'll say that again. That'll be my ending line for the night. Right when I asked when I asked Doug Lamborn about his support of the PACT Act, the response we got back from his office was it is too expensive to provide health care to veterans who were injured as a result of their service to our country. That is not just Doug Lamborn's view, but that is the view of the Republican Party. That is how the Republican Party thanks us for our service. We're too damn expensive. Thank God we got a nice cemetery back there.
Okay, thank you, Joe, and till next time. This is Joe Reagan's Conversations. Thank you.
Thanks, everybody.